Hello, and welcome to this web series dedicated to sharing key insights on tools and technical assistance based on the work that was done in collaboration between Boston Consulting Group and California counties between the fall of 2025 and the summer of 2026. Today's session is focused on peer support specialists, who they are, what they do, how to bill for their work, and what it takes to build a peer program that actually sustains itself over time. Whether you're a program manager, a supervisor, a clinician working alongside peers, or someone who oversees billing and documentation, I think there's something useful here for you. So let's get into it. Let me take a quick moment to walk through what we're covering today and what I hope you walk away with. We have four goals. First, we want to make sure everyone leaves with a clear sense of why peer programs matter, not just philosophically, but practically in terms of what they do for clients and for counties. Second, we want to build shared clarity on what peer support specialist role actually is, and just as importantly, what it is not. Third, we'll spend some time on billing codes and documentation requirements because getting that right is what makes peer services financially sustainable. And fourth, we'll close by talking about what it takes to build a strong peer ecosystem at the program level. So let's start with the question on this slide. Why do we focus on peer support services with counties? The honest answer is two things that are deeply connected. The first is that the unique role that peers play in a client's journey. When we were doing this work with counties, one of the things that came up over and over again is that there are moments in a client's recovery, moments of doubt, moments of transition, moments where they feel like the system just isn't built for someone like them, where a clinician or a case manager can only do so much. And it's in those moments that a peer support specialist, someone who's actually been through it, can make a connection that changes everything. That's not something you can train into a role. It comes from lived experience. And that makes peers genuinely irreplaceable in the care team. The second reason that peer support services are still relatively new as a Medi-Cal benefit. And so California launched this in 2022, and a lot of counties are still building the infrastructure to make it work. They're still figuring out how to define the role, how to supervise peers appropriately, how to make sure notes meet billing standards. And that means there's real opportunity on the table when it comes to FFP. Counties that can get the infrastructure right can draw down federal reimbursement for work that peers are already doing, but that only happens if the program is built on a solid foundation. So let me be a bit more specific about the value peers create, because I think it's worth naming concretely. It can be grouped into three areas as outlined on this slide. The first is improving client engagement. Peers help clients stay connected to services, not just by checking in, but by meeting them where they are emotionally. A client who doesn't show up for their appointment isn't necessarily unwilling to engage. Sometimes they just need someone who gets it to remind them that recovery is possible, and peers do just that. The second is strengthening continuity between services. The behavioral health system has a lot of handoffs between programs, between levels of care, between inpatient and outpatient, and those transitions are some of the highest risk moments for disengagement. Peers can stay with a client through those transitions in a way that keeps the thread of recovery going, even when formal service relationship changes. The third is extending recovery support beyond formal treatment. So clinical services have a start and an end. Recovery doesn't. Peers help clients build the connections, routines, and supports that carry them beyond what the formal treatment system can provide. And the implication for counties, which we call out at the bottom of the slide, is that in most places, peers are already doing this work. The question isn't whether it's happening. The question is whether you have the structures in place to recognize it, document it, and build on it. So let's move into the definition of the role itself. And I want to start with the formal definition and then we'll make it real. So a peer support specialist is a certified behavioral health team member who uses their own lived experience of recovery to support, guide, and motivate clients. That's the definition. And it matters because it says This matters that it says certified because in California, becoming a peer support specialist requires at least 80 hours of core training and passing a certification exam. It is a recognized role with a defined scope. So peer services are also a standalone Medi-Cal billable benefit, and that's important. They don't have to be attached to a clinical service to be billable. A peer can work with a client who isn't active in SMHS treatment. They can also work alongside someone in DMCODS. The peer service stands on its own. And on the bottom of the slide, we describe the role in three ways. First, it's grounded in lived experience, which means that the peer shares their story purposefully, not as therapy, not as advice, but as a way of saying, I've been where you are and I made it through. Second, it's recovery oriented, meaning it centers the client's own goals and agency, not a clinical agenda. And third, it's complementary. It expands the care team's reach without replacing clinical judgment. So let's make this a bit more real. This slide is one of the most important ones we'll cover today because scope clarity is the foundation of everything else. If peers and their supervisors don't have a shared understanding of what's in and out of scope, you end up with two problems. Either the peers are being used for things that they shouldn't be doing, or they're not being given credit and documentation support for what they are doing. So on the left-hand side, you'll see what the peer role is. Peers use lived experience to build trust and instill hope. They help clients stay engaged. They support skill building and system navigation. They can co-facilitate groups, and their services can run alongside any level of care. But on the right-hand side, you'll see what it is not. Peers do not diagnose. They do not develop treatment plans. They do not modify level of care. They don't give medication opinions, and they shouldn't be used as administrative staff. And most importantly, they cannot bill clinical codes. So the examples below the table are where this gets real. A peer sharing their recovery story with a hesitant new client in scope. A peer helping a client prepare questions for their doctor, also in scope. A peer conducting a clinical assessment or telling a client what medication they should switch to, not in scope. Now, one thing I want to be clear about is state guidance sets the parameters, but each county is going to need to define how this plays out in your specific programs. What does engagement look like in a DMC ODS setting versus a specialty mental health setting? Who does the peer call when something comes up that's outside their scope? These are the types of questions that counties need to answer in writing, and we'll talk about how to do that when we get to the TTA playbook section. And so let's cover and talk about the three service categories because understanding these is what helps peers and supervisors recognize when a session is billable and what to call it in the documentation. So the three categories are engagement, therapeutic activity, and skill building and education. Engagement is the most common starting point. It's the work peers do to help a client connect to services, build trust, and feel ready to participate in treatment. This is especially important at transitions. When a client is returning after a missed appointment, when they're new to a program, when they're ambivalent, engagement is how you bring them in and keep them in. Therapeutic activity is a bit different. It's structured, non-clinical, that supports recovery. So things like helping a client practice a real life skill, supporting them during an appointment to build their confidence, or helping them connect to community resources or natural supports. And then finally, skill building and education is about helping a client learn or practice something. So these could be coping skills, communication skills, recovery tools, daily living tasks. This can happen one-on-one or also in a peer facilitated group. And one thing that trips people up here is that these three categories all bill with the same two codes, H0038 for individual and H0025 for the group. The category is a clinical documentation distinction. It doesn't change the billing code. What matters is that you pick the category that reflects the primary focus of the session and document it accurately. And one more thing worth flagging is that services can be delivered during transportation. If a peer is driving a client to an appointment and they're doing purposeful peer support work during that ride, that time may be billable. But really, really important note here, the transportation itself is not the service, and that's not the billable service. The peer support conversation is what is. So I kind of alluded to this, but let's get into the specific billing codes. There are really two codes, as I mentioned, that cover nearly everything peers do. H0038 for individual peer support and H0025 for peer group. There's also an H0050, which is for a structured brief intervention, so a specific motivational enhancement session using a screening tool like Audit or DAST. And that one's more specialized. So we'll primarily focus on the top two here. So H0038 is a one-on-one session. So this could be any combination of engagement, skill building, or therapeutic activity with one client. On the other hand, H0025 is a group session. So two or more clients, and it's usually a recovery, support, or education groups. And what I want to draw your attention to on this slide is the common note language column. These are templates, not scripts, but structures. And the key components are what the client had said or presented, what the peer did, and specifically how they used their lived experience, then how the client responded, and what will happen next. The last part, which is the plan of what's going to happen next, is one of the most commonly missed elements in peer notes, and that leaves a huge risk for the note to get kicked back. So every note needs to include the date, time, location, the correct service code, direct service time only, not the travel time or not the documentation time, and a link to the client's active treatment goal. And finally, a client signature for in-person visits. And I want to be clear here, we're not lawyers, and counties should always work with their own legal counsel and finance teams when it comes to billing decisions. But the documentation framework here is grounded in DHCS guidance, and getting it right is what protects the work peers are doing from being questioned. All right, so now let's make this a bit more real. This slide is just one example of how to structure a note and can be useful for anyone who supervises peers or does documentation training. So on the left, you'll see the BURP framework, behavior, intervention, response, and plan. This is a structure that works really well for peer notes because it maps directly onto what actually happens in a session. So behavior, that is what you observed when you walked in. How did the client present? What did they say? Were they engaged or withdrawn? This is not a clinical assessment, it's just an observation. And whenever possible, you want to write the quote the client said directly, because that specificity is what makes the note credible and very useful. Intervention, that is what the peer did. And this is where a lot of peer notes fall short. They say provide peer support and stop there, but that's not enough. What specifically did the peer do? Did they share a piece of their own recovery story? Did they help the client practice a conversation? Did they work through a barrier together, maybe? The intervention note should be specific enough that someone reading it could picture what happened in the room. And then response is how the client responded. Did they become more engaged? Did they shift in their seat and open up? Do they express doubt or resistance? This is important because it shows that the peer was paying attention and that the service had an observable effect. And then plan, that's what comes next. Even one sentence is what you need here. The client will practice the conversation with a family member before our next session, and then the peer will follow up by phone midweek. That's all it needs to be, but it needs to be there. And then on the right-hand side here is just a sample note. So I'd encourage you all to use this as a training tool with your peers. Walk through it section by section. Ask them what makes this note strong. Maybe what would you add? The more comfortable peers get with this structure, the better their documentation will be and the less time supervisors spend on review and corrections. So let's take stock of where we are before we continue into the final section. So we've covered why peer programs matter, the unique role that lived experience plays in a client's journey, and why California made this Medi-Cal benefit in the first place. We've also covered what the peer role is and what it's not. And I hope the in-scope and out-of-scope examples made that feel really concrete and actionable rather than abstract. And then we've gone through documentation and the billing basics. Just remember the two main codes, the BURP framework, and what a strong note looks like. And all of that is about what peers do and how they document it. Now I want to shift to a different level of the conversation because knowing the role and knowing the codes is necessary, but it's not sufficient. What really determines whether a peer program delivers consistent value over time is the infrastructure you build around it. And that's what we're going to focus on for the rest of our time together. So, building a strong peer ecosystem requires alignment across 5 dimensions. And I want to walk you through each of these because they're not independent. They reinforce each other, and gaps in any one of them tend to show up as problems in the other. So, starting with the first dimension, it's core philosophy. This is your vision and your purpose. This is the foundation. So, why does your county have a peer program? What are the principles that guide how peers practice? If people across your program can't answer those questions consistently, you'll get drift. Peers in different programs will operate differently, and it becomes very hard to train, to supervise them, and to build on. The second is systemic and structural clarity, which covers the peer role, the senior peer role, and team integration. So this is about making sure peers know what they're responsible for, supervisors know how to support them, and the rest of the care team knows how to work alongside them. When this is missing, peers often end up being used for things outside of their scope, or worse, not being used at all. The third element is enablement. So this is guidance, workflows, onboarding, and training. This is the day-to-day infrastructure. So can peers look up something when they have a question? Is there a clear process for what they do in a complex situation? Is there a structured onboarding experience when someone starts? These things make a difference between a peer who feels supported and a peer who feels lost. The fourth is practice and capabilities. So supervision, tools, operational supports. Supervision for peers is different from clinical supervision. It needs to be strengths-based, reflective, and grounded in the realities of peer work. And the tools, checklists, note templates, reference guides, these need to be practical enough to use. And then finally, the fifth here is recruitment and hiring. Peer programs can't sustain themselves if there's no way to bring in and develop new peers consistently. And recruitment for peer roles is different than recruitment for other positions. You're looking for someone with the right combination of lived experience, skills, and readiness. So when we've worked with counties on peer program infrastructure, we often help develop what we call a peer playbook. This is a structured document that brings together all 10 of the elements you see on this slide. And I want to be clear about what the playbook is and is not. It is not a policy manual. It's not a training curriculum. It is just a practical reference, a single source of truth that tells peers, supervisors, and program managers and leadership what the program stands for, how it will operate, and what's expected of everyone in it. The 10 elements map directly onto the 5 dimensions we just discussed: vision and purpose, peer role, senior peer role, team integration, guidance and workflows, onboarding and training, supervision, tools, organizational support, and recruitment. And each of these becomes a module in the playbook, and each module is designed for a specific audience. So one thing I want to emphasize is this doesn't have to be built all at once. We recognize 10 modules, 10 sections is a lot. But when we work with counties on this, we typically start with the elements that are causing the most friction. Usually this is role clarity and supervision. And then we build out from there. The goal isn't a perfect document on day one. The goal is to be a living document that's useful now and can grow over time. So the playbook serves 4 goals, and I want to name them because they directly address the problems we hear about often from most counties. First, it creates a single source of truth. One of the most common things we hear is that guidance is scattered. It's in one email, and it's in one training from 2 years ago, and in a document that someone made when the program launched. The playbook pulls together all of that so that when a peer or a supervisor has a question, they know where to go. Second, it establishes system-wide consistency. This matters especially for counties with multiple programs or sites. When the peer role is defined differently across programs, you get inconsistent outcomes. And therefore, you get risk on the both clinical and billing side. Third, it's designed to be principle driven, meaning it's not just a rule book. The best playbooks we've seen are the ones where the guidance reflects a genuine philosophy about what peer support is and why it matters. That's what makes it something people actually use, rather than something that just sits on the shelf. And fourth, it supports claimability. And this is the connection back to everything we talked about earlier today. When peers understand what's in scope and have clear documentation, the note gets better and the claims hold up, allowing counties to really draw down more FFP. And finally, one more thing that I just want to say about the playbook before we get to the sustainability of it is that it serves a lot of different functions depending on who's using it. So for a supervisor, it's a coaching tool, a shared reference point for supervision conversations and performance discussions. For a peer, though, it's a reference hub. It's the place you go to when you have a question about scope or documentation or what to do in a complex situation. For someone doing onboarding, this is a training guide. For program leadership, it's a communication platform, a way to make sure that values and expectations of the program are clear and consistent across the organization. So the point is that this one document can serve all of these purposes if it's well designed. And that design work is what we've been helping counties with. And so then the last thing I just want to cover here is how to sustain the playbook over time, because a document that doesn't get updated quickly becomes a document that doesn't get used. So there are 4 things that make a playbook sustainable. The first is ongoing feedback loop. Peers and supervisors should be able to flag questions, suggest changes, or identify gaps at any time. And the patterns that come out of supervision, the coding questions, those edge cases, things that keep coming up, those are great signals about where the playbook needs to be strengthened. The second is consistent distribution. So whenever the playbook is updated, the update needs to reach peers, supervisors, senior peers all at the same time, and through channels where those updates actually land, not just in an email that will get buried. The third is an annual review cycle. So program leadership and the peer services division should set aside time once a year to look at the playbook very comprehensively. And this means checking it against any changes to Medi-Cal policy, documentation standards, or program structure. And then the fourth is a clear update process. So changes shouldn't happen organically. They should follow a defined pathway that includes review for accuracy, scope alignment, and feasibility. And when a new version goes out, it should be clearly labeled so everyone knows what changed and when it changed. Counties that build these habits into how they operate will find that the playbook stays relevant and useful, and that it becomes this kind of reference that people actually reach for when they have a question. And so I just want to close today by saying thank you, genuinely. Peer support specialists are doing some of the most meaningful work in the behavioral health system, and the fact that you're investing time to understand and strengthen that work matters. We've covered a lot of ground today. The core message I want you to walk away with is this. Peers bring something that the formal care system cannot replicate. And when you build the right infrastructure around them, clear roles, solid documentation, good supervision, a shared playbook, you unlock both better outcomes for clients and sustainable funding for your programs. These 2 things are not in tension. They reinforce each other. So thank you for listening today, and please take care.